Thank you for the kind introduction. And I have nothing to disclose. I'm going to let you read the cartoon. Yes, I am Employee of the Month again. And yes, I'm the one who chooses the Employee of the Month. And no, I do not see a conflict of interest. So here are our objectives today: to describe pediatric sports injuries involving both the lower and upper extremities that may be seen not only in the ED, in the urgent care, but also in your clinic. Identify specific pearls to help you narrow your differential diagnosis, and discuss possible pitfalls when evaluating and managing pediatric sports injuries. So my initial pearls I want to give to you is, with a good history, you should arrive at the correct diagnosis 90% of the time. And hopefully you remember that's what you're taught in your medical school education. And at least get to a confident top 3 differential. With a good history and a comfortable knowledge of the anatomy, it will make your exam focused, quick, and efficient, and give you more time to chart, which we all need. And with a good history and comfortable knowledge of basic anatomy, you will not need to palpate until the end of the exam. Because if you do palpate at the very beginning of the exam, you risk letting your patient not finish the exam, because they will be very apprehensive and they won't want you to touch them. So the history, we all know how to take a good history. I actually just got an appointment teaching the JMP students at UC Berkeley, for those of you who know about the joint medical program, so I'm really, really excited about that. And I'll be able to teach them a lot of history taking, which I think is key for anything, regardless of whether that's a musculoskeletal injury or a lung issue or anything else. But you want to talk about all of these things, and these will be, I think you have access to these handouts, so I won't belabor the issue. One of the things about musculoskeletal, though, is we're going to point out some of these things. The swelling is important. Whether or not they have mechanical symptoms is important as well. Having the mechanism be acute or chronic or overuse really gives you a good idea of the acuity and the urgency of the situation. And I always ask if it's chronic or an overuse. If don't be mistaken if they come and they say, "Oh, it's been going on for 3 years." Always ask the question, what brought you in then today? What made it different? Because it's the difference that's going to be important. And then again, of course, the symptoms in terms of the pain, and then the modifying factors, which include all of these. If you care to ask them, sometimes they'll be important. Oftentimes, talking about overuse injuries, it will be important in terms of the pitches per week, for example. And I've seen 2 young boys who are 12 and younger who have pretty significant elbow injuries, which shouldn't ever happen in that age group. So I'm going to use the knee as an example because it's really the easiest sometimes in a way of looking at this anatomy. And so when you look at the medial knee, and Frank Netter, a wonderful author, and when I first came to work here 3 years ago, I bought all kinds of the Netter anatomy books to place at every single one of my clinics, which I was surprised didn't have any. And I am really into patient education as well as residency education, so it's really important to me that if the patients don't know what's injured and you haven't shown them just a brief picture of what's injured, it's hard for them then to do the things they need to do to get better. So if you look at the medial knee, you could take a just look and correspond what's going on in the medial aspect of the knee, knowing that the patella is here, your pes anterior bursa is here, boom. Your MCL is here, MCL, and then you've got your joint line. Your joint line comes across here. So knowing that, you can go ahead and then you can look at the lateral knee, and what was one of the quizzes was the biceps femoris. The biceps femoris tendon comes down here and inserts on the head of the fibula, okay? So we've got to make sure we know about the biceps femoris tendon. I don't have it identified on here, but on this anatomical picture of someone who's obviously very fit, my knee doesn't look like this, but here's the biceps femoris tendon. Do you see it coming all the way down and inserting on the fibula? And there's your iliotibial band here, your dreaded IT band, which sits here on Gertie's tubercle, okay? So you just kind of align it in here, you get the patella and the lateral joint line. If you then look at the anterior aspect of the knee, you've got the patella tendon, tibial tubercle, where all of our Oscar-Schlatter type of patients sit, your medial joint line, lateral joint line, Gertie's tubercle is here, pes anterior is here, quadriceps tendon comes down here and inserts here, okay? And then your posterior aspect, right? You've got this diamond that's shaped by your medial hamstring and your lateral hamstring, biceps femoris, semimembranosus, and tendinosus, and then your gastrocs coming up. So we know that these are the structures here, medial, lateral, and these are the tendons that come down. So knowing your anatomy, or at least a general sense of it, is pretty key. And in the skeleton immature, almost all of you got these correct. Bones are weaker, and we need to think about the bones. So why is that important? Well, apophyseal injuries, okay, so there's apophyseal injuries, and there's physeal injuries, and we're going to talk about both of them. So the apophysis is a specific tendon attachment associated with the underlying growth plate, and it is weaker than the muscle tendon unit itself. An acute injury can happen when there's a sudden forceful contraction or eccentric contraction. Our chronic is repetitive stress to maturing apophysis, and that goes along with growth spurts can affect these apophyses. And so we're going to see a lot more chronic in the clinic, and the acute is probably going to be likely more the ED. So let's look at those growth spurts. We've got the growth spurt that occurs just after birth. And for those of you that got them correct, which is again almost all of you, the juvenile growth spurts happen the ages of 6 and 7 for girls, 7 and 9 for boys. I may have gotten that question incorrect. Okay, well, this is correct. The slide is correct. And the pubertal growth spurt, 10 to 12 and 12 to 15. Now we oftentimes, and parents oftentimes, only think about this. And this is when we're getting a lot of ours, but these are the growth spurts that happen as well. Unfortunately, this is what we're seeing now more often than ever before with organized sports, is you're getting everyone coming in with apophyseal injuries at these ages because of the travel, soccer, and baseball, and everything else that's happening at a much younger age. It used to be a lot of recreational soccer, and then if you're a pretty good athlete, then you get into this range where now you're on travel. Now it's happening much younger. So the apophyses are all over our body, right? And so when people rotate with me, when the residents rotate with me, we invariably get an injury that comes in with here, but here's the ASIS, the iliac crest, the AIIS. All of these apophyses come off of the pelvis, and then you've got the ones that come off of the knee and come off of the foot. So for example, all of these wonderful names, which we have to memorize, we're comfortable with Sievers, Oscar Schlatters, but Sinden Larsen Johansson is the apophysis that occurs at the inferior aspect of the patella. And you can tear this apophysis off, and there can be a huge amount of swelling, which one of my first cases as a fellow back in 1992 was this. Isolin's disease is injury to the apophysis here where the peroneus brevis inserts. So we look here. Pediatric bones are totally different in terms of that. Abdominal muscles attach here, your sartorius, rectus femoris, glute medius minimus, iliopsoas. This happens a lot. Rupture of the hip flexor, iliopsoas, off of this lesser trochanter apophysis. And then you got your hamstrings, very common, your adductors off the pubic symphysis. And then here, I'm not sure if we can see it or we can turn the lights down in the beginning, in the front of the room, but at the ages of 3 and 9 and 15, this is how the foot changes. And you can see here, you can see this little area here, this is not a fracture, this is the apophysis of the base of the 5th metatarsal. Do you see that there? And then by the time we get to a 15-year-old bone, it's fairly fully mature. Do you see this growth plate here? Gone. Now, look how that's important. Here is injury to the base of the 5th metatarsal. You can see that vertical line. Here is a perfectly okay foot. No fracture at all, fracture here. So knowing these apophyses are very important when looking at an x-ray. And again, here's an example of elbow at the age of 3, at the age of 9, and at the age of 13. And look at that transition that happens with that. This brings us to your ossification centers. We all remember Crito. So 1, 3, 5, 7, 9, 11, odd numbers in terms of the appearance of the capitellum, the radial head, the internal epicondyle, which is the medial epicondyle, the trochlea, okay, the olecranon, and then the external epicondyle. And you can remember that in terms of the appearance of the ossification centers. So physial injuries are different. So physial injuries are within long bones, and they help with growth. And this is one thing that I don't know if I made it up, but probably some other brilliant person thought of this beforehand. But this is how I remember the Salter-Harris fracture classifications. So this is a typical diagram. You guys all remember this, right? In all of your textbooks. So this is the joint sitting down here, we're going to assume. But this is the way the bone is, okay? The type 1 is a slip or straight across. This is more often what we're going to see. Patient is tender here. Fracture of the cartilage of the physis, the growth plate. Straight across, Salter. Type 2 for A is away or above. The fracture lies away from the joint or away from the physis. It's really away from the physis. Here is A above. And I visualize this when I think about it. So if I'm looking at another long bone but they're reversed, then I have to reverse my visualization, okay? 3 is lower. The fracture is lower than the physis in the epiphysis, or closer in this case to the joint. For T, it's through everything, TE. The fracture is through the metaphysis, the physis, and the epiphysis. Okay, so your type 4. And lastly, your type 4, you're rammed, which I've never seen, but it's a crushed. The physis has been crushed, okay, or rammed. So that's how I remember. So physial closure, there's estimated ages of fusion for the proximal or the medial, depending. And you can always look this up. I don't have this memorized per se. I have a great textbook that I use in my clinics, which shows you the appearance of the ossification centers and the physial closures. But again, we're looking here, and again, at the age of 6 and 15, at the ages of 6 and 15, these are how the physes appear at the age of 6 and how they're closed by 15 here. Same thing goes in the knee laterally. And this is really important in terms of the impact of growth, because if you look at this, and this is really a good diagram that I like, is that when we look at the distal femoral and the proximal tibial physes, and this is the knee joint, it contributes more to the limb length than the hip and the ankle. And overall, 65% is contributed by the knee. And if you look at here then, estimate average distal femur grows 1.2 centimeters a year, and an proximal tibial 0.9. Closure occurs then. So this is really very key, because this is why physial injuries are so important, because it does contribute to growth. So we're going to jump into some cases. We've got a 13-year-old male with right knee pain, playing basketball with friends as he went up to dunk, 13-year-old, dunk the ball. They all think they can dunk the ball. His leg got tangled up with a defender when he was jumping, and his knee got caught and gave out under him. It swelled up immediately. It was too painful to bear weight, and he was unsure if he felt or heard any pops. So physical exam trauma, very first thing I have them do when I have someone traumatic or non-traumatic, and they're in my office, I say, well, point to where it hurts. So if they can point directly where it hurts, knowledge of the anatomy, it gives you a good idea of what's going on in that area. If they go like this, then they don't help you at all. It's like, well, where's Waldo? So then you have to distinguish between a fusion, which is soft tissue, a fusion which is in the joint, versus soft tissue swelling. So here's an example here of a fusion, normal knee, and a fused knee, okay? And this is the area here, all right, where you can feel the joint line, either on the medial side or the lateral side, where you can see if it's puffy. And why is that important? I oftentimes will say, did your knee swell? Maybe they came in 2 weeks later, did your knee swell? Oh, yes, it was swollen. Was it swollen like a watermelon, like a melon, like all the way around your knee, or is just one part of your knee swollen? And you need to distinguish that, because if it's just one aspect of the knee, then maybe we're talking about a soft tissue structure like an MCL here, or patellar tendon here. But if it's like swollen like a melon or a ball, then we're thinking about something intrinsic inside the knee, a meniscal tear, a ligament sprain, etc. Okay? And then here it is. Look for any superficial abrasions or bruising. You've got to have them take off their skinny jeans. You have to help them unclothe to see this. And if it's really tight and they're pulling up leggings or something, and they can barely get above the knee, please have them change. Most people aren't so modest about being in boxers or underwear if they don't have shorts, or if your clinic doesn't have shorts, if you've run out, or shorts don't fit. But what you can do is have them unclothed take a gown, even a paper sheet, and tie it around them, okay, like a skirt, so that you can see the knees. It's very, very important. Perform an active straight leg raise. They can do this. Even if it hurts, say, I need you to do this for 2 seconds. I'm going to count with you. 1001, 1002, okay. Because you've got to see whether or not this extensor mechanism is okay. You don't want to miss an avulsion fracture or something going on in this area, or patellar fracture. Okay. You want to check ligament stability. This is a Lockman test, okay? I don't use the anterior jaw to check for the ACL. It's really unreliable. I use the Lockman test where you're pulling up to check for the ACL. But I do use this position to check for the PCL, okay? The PCL where you're pushing back. That's that arrow here, okay? Valgus stress and varus stress is to check for the MCL and the LCL. And the figure 4 test, also you can palpate the LCL. And then joint line tenderness. Here, you can palpate along the joint line for the meniscus. Okay. Patellar apprehension. They are going to have a face like this. Do not do it. Oh, no. And what you do is you try to laterally glide. You put medial force to laterally glide patella. And they'll tell you if they don't like it. That perhaps will give you a clue about patellar subluxation or dislocation. And what about x-rays? For traumatic injury, you need to get an x-ray. Here, you see how there's an anterior aspect and a posterior aspect of plateau? You don't see that on this side, and there is a fracture line coming through, okay? So what about getting an MRI? Well, oftentimes you will perform, you'll refer if you're worried. But this is what I want to show you too, is another example of this. So this is more of an acute injury. They can't extend the knee or perform a straight leg raise. So you can have an acute fracture of the apophysis, of the tibiotubercle. Or in this case, look how high that patella is sitting, right? Something's wrong. That patella, see that patella? It needs to be here. It needs to be here. You don't have to do any fancy measurements to know that something's wrong. But on this case, they had a sleeve fracture. And you can't really see anything on this x-ray. And the reason why you can't see it is because the cartilaginous aspect got pulled off, okay? And in that case, then an MRI would be helpful because this is what the MRI would show you, okay? That area here, that's on the quadriceps aspect, got pulled up, okay? So, and this is patella here. So really, doing a straight leg raise is key. Okay, these are the x-rays you can get. AP lateral, notch or tunnel, and a merchant view. So the one thing that I want to point out here is this is your notch or tunnel view, where their knee is bent, and then the x-ray is taken, 30 degrees. This is your merchant view, okay? Why are these views important? Oftentimes in trauma, you will get an AP lateral, and then maybe you'll get an oblique here. For trauma, that's probably okay, except, let me show you this. Here an x-ray, here's your notch view, okay? You don't see cartilage, you don't see meniscus, you don't see ACL or PCL. You can't see the tibial spine. But on a merchant view, you can see things like this. You can see how that kneecap is laterally tilted, distracted, but look at this. There's a little fracture there, okay? And you wouldn't have seen it otherwise if you've gotten just a straight AP view, all right? And that can happen with a patella dislocation. Here's your tunnel view. And on the tunnel view, on the tunnel view, you can see, more likely you can see OCD here. You see that there? So osteochondritis dissecans is more easily seen on a tunnel view than just an AP view. So sometimes with chronic knee pain, sometimes with an effusion, catching, locking, you may want to get those extra views, or depending on the trauma, okay? Here we go. MRI, torn ACL, gone. Intact ACL here, torn here, intact PCL through there. Okay. And so what about this? What about the ACL? Well, we know, and plenty of studies have shown, we used to hold young boys and girls if they've torn their ACL because we wanted to wait for their growth plates. And I think Dr. Pandy has probably given you a lecture, or he will be. But what happens is if you wait to fix an ACL, or you don't at these young people, you're going to get all of these symptoms and really gnarly arthritis in our kids. So what we tell kids and adults, because I do adult sports medicine as well as pediatric, is what is activity like without an ACL? Straight ahead is okay. Cutting, pivoting, no. So I tore my ACL when I was 22, 21, and I was told, okay, you know, you're a medical student. You're in your first year. You're a woman. You can do jogging and running. That's okay. You don't need your ACL. Well, you know what? I played basketball. I played volleyball. And it was hard for me to stay away from the things that I loved. And I did a lot of damage to my knee after that. So it's hard, though. How do you control? And I was adult, right? I was a first-year medical student. I'm supposed to know what I can or can't do. But how about kids? If you tell kids, okay, you can't cut or pivot, forget about recess, forget about all the things you want to do with your friends, but you can only do straight ahead. It's not going to work. So operative treatment, quickly, I wanted to tell you this because oftentimes people may come in and say, I need to get in right away see a specialist. I've got a problem with my knee. And you've determined that, yes, you're absolutely right. But, you know, prior to even operating, you need full range of motion. You need to be weight-bearing without crutches. You can't have any swelling in your knee. You have to have good leg control. You can't give out. You have to have good quad control. So there's no reason to get in right away because surgery is not an emergency. It's going to take people usually about 2 to 3 weeks anyway. So I want to point that out to you. If you have people like calling you or emailing you all the time. Okay. So for knee MRI, joint line tenderness, this is all the things you can see. Meniscal, bone bruises here, cartilage damage. And tears, boy, I could talk forever on just the knee. So here, meniscus tears, key history and physical, acute versus chronic, acute painful swollen knee from meniscus, locking, catching, typically associated with an ACL, pain with deep squatting, and joint line pain. You can have posterior as well. If it's deep in the knee, that could be the meniscus as well because of the way it wraps around. And here are some examples of what they look like. And the type of tear is a vertical, horizontal tear, and this is a complex. Okay, and remember, bucket handle tears can happen. This is what it looks like anatomically, and it flaps into the joint. So this is some of the meniscus, and that's the other part of the meniscus. And oftentimes their knee will come in locked. That's an emergency. That needs to get in to see an orthopedic surgeon or someone in the orthopedic department to operate on. And again, I'm primary care sports medicine, so I don't operate. And many people think I do because I'm in the Department of Orthopedics. But I do, I'm going to say this, injuries and illnesses related to sports and exercise. That is what I do. Injuries and illnesses related to sports and exercise. Okay? All right. Here we go. So we're going to breathe through this. OCD we talked about. You can see this on X-ray or MRI. And that's the history. Vague, poorly localized. It's deep in my joint. Swelling, stiffness, worse with twisting or cutting, and locking and catching can occur. And there's various degrees of damage, and this can be what it looks like when you look and scope them. So on physical exam, they've got effusion, decreased range of motion. They're tender over the femoral condyles, and you can do McMurray's type of test to determine that, or you can load this way, an Apley's to see. And what is OCD? It's really hard. I love saying OCD because people think, what? I turn off the water. I don't check it all the time. But cartilage and a piece of bone detached from the articular surface. It can be traumatic or developmental. So keep that in mind. People can say, I never had an injury. How did I get this? But if they were very active at a young age, and as a form of like AVN almost, that's developmental. And we never x-rayed them because they didn't really ever hurt. And there's two groups, juvenile, where the open growth plates, and that's a better prognosis than an older adult where the growth plates are closed. And I've seen plenty of young people at UC Berkeley coming in, and they have the OCD. And that's a really bad diagnosis when they come in with that. Untreated, it can lead to early OA, chronic pain, functional impairment. And these are the majority of the locations. This is the medial femoral condyle, okay? All right, MRI findings. Patellofemoral pain, we need to get this. Acute dislocation or subluxation, there's a pop pop. Why is there a pop pop? And I always ask, did you hear a pop? Yes. Did you hear two pops? Because think about it, if they're going to dislocate, the kneecap is going to go pop, and then it's go back into place, pop. Okay? So don't be surprised if they say pop pop, but ask about that. Subluxation, it just goes pop, kind of shifts. Okay? There is a joint effusion. For chronic overuse, which is more likely what we're going to see patellofemoral pain, usually there's no trauma, except maybe 6 months or 3 months prior they fell on their knee. Okay? And it was okay, they had a scrape, but then they began to have patellofemoral pain several weeks later. Pain associated with running, lunging, squats, sitting, soft tissue swelling. Okay, so again, you do the apprehension test. You can see this on a merchant view. On an MRI, you can see this is a chondral injury. You see there's a gap there in the cartilage. So they hurt their cartilage with a dislocation. Patellofemoral syndrome is usually no trauma, but can occur after a remote minor injury. The dull pain around the patella or deep inside. And sometimes I say to them, does it feel like if you picked up your kneecap, that's where the pain is? Like right underneath. Yes, that's where my pain is. Feels like sandpaper. They could be playing sports all the time. Stairs or sitting for a long time, the theater sign which we learned about. Or video playing sign, how times change. You know, sitting there and playing video games. Fairly benign, but they lack flexibility and core strength. Okay, for the residents who have been with me, these are the keys, right? Crepitus with knee extension, positive patellar compression test, where you hold on the patella and you have them contract. Pain on palpation of the medial facet, okay, because that's where the medial patellofemoral ligament sits, and that's the one that's pulled. Or they have increased patellar mobility. It's easy to move their kneecap around. These are the two things I do in the office. A single leg squat to evaluate for weak quads or glutes. So this is a good single leg squat. Knee is aligned over the second toe. This is a not so good. They can't hold their pelvis, their knee goes into valgus. So here's an example of a runner. Knee is going into valgus. Someone who's attempting to lift weights, knee is going into valgus. This is set up for patellofemoral pain because it's not tracking well. Rather than tracking like this, you're tracking like this. And Thomas test. Learn the Thomas test, have them line the table. If their hip flexor is tight, they're not going to be level with the table. Okay? That is key. Also look at them from this perspective. If their leg is straight, they're good. If it's actually abducted at all, their TFL and their IT band are tight, and those two structures can cause problems with the kneecap and patellofemoral syndrome because it's not in the right place. It's being pulled too laterally and too superior because of a tight hip flexor and the IT band being tight. If you show people this, and usually it's their parents and they go, oh, you know, it's like, this is why you have to stretch. If you just give them stretching exercises, or the PT does, oftentimes they don't go to PT. And you've got two things to give them. Well, if you point this out to them, maybe they'll do it. Okay, and here are the risk factors. Training errors, trauma, oftentimes we need to ask about as well. But these are the lateral structures, etc. Okay, ankle injury. 14-year-old female playing a basketball game, she turned her ankle inwards. Okay, came down another foot. She felt a pop, she couldn't bear weight, immediate swelling. Next day, swelling and bruising, most tender over the front and lateral aspect of the ankle. Again, here's your anatomy. Okay, knowing the anatomy, your ligaments, where they sit, ATFL. Here, I don't want you to forget, is your syndesmosis ligaments. Okay, the ligament that attaches your tib fib and the ligament back here. Okay? So, what do? In this case, she had moderate swelling of a fusiform in nature of the ankle and the anterior lateral ankle. Some people say it swelled up like a golf ball, just here. But if it looks like it's swollen all around the ankle, fusiform, that's something different. Look how this swelling pattern and bruising pattern happened from an ACE wrap. But that means that something was swollen, injured right here. as opposed to the bruising pattern just being down here in the heel or down here in the ankle. So do a squeeze test where you're squeezing here. Don't forget, starting up here all the way down, because you want to check for pain along the fibular head and the fifth metatarsal. You want to make sure that when they turn their ankle, they also didn't fracture their fifth metatarsal or their fibula. Okay? Do the squeeze test. All right. What is a syndesmosis injury? I think we need to explain this because a lot of people are not comfortable with it, but this is what the media or the press or what you hear about a high ankle sprain. And sometimes kids go, oh, high ankle sprain. Anyone that reads Sports Illustrated, they'll say, oh, I know that. So-and-so was out for 3 games because of a high ankle sprain. Okay, well, this is what it is. This is the syndesmosis, the interosseous membrane, right, that sits in between your tib and fib. And at the very bottom, it thickens, and it becomes the anterior inferior tib fib ligament, anteriorly, and posteriorly, it's the posterior inferior tib fib ligament. I love this diagram. This is your axial because here's your tib, here's your fib, here's the ligament here, here's the interosseous membrane, and here's your, your anterior one, and here's your posterior one, okay? So you can sprain those ligaments, and that means that instead of a 3-week injury, it becomes a 6 to 8 week injury. So it makes a big difference knowing that, okay? So here's some of the tests: anterior jaw, okay? The sprains, grade 1, grade 2, grade 3. At grade 2, you're going to get an endpoint. Here are your ligaments, okay? You can do a talar tilt. That's to look at the calcaneofibular ligament. The anterior jaw is to look at the anterior talofibular ligament. And again, here's a Frank Netter depiction of a complete tear, grade 3. So ligament test, again, depicting here, talar tilts to look at the various ligaments, and this is what it looks like anatomically. If you do a talar tilt and it opens way up, that means that your ligament has been pretty much torn, disrupted pretty well, okay? And then ankle x-rays. Here are the views you're associated with. OCD, you want to look carefully. Get them. Here's the anterior. Here's just the AP view. And this is a AP view. Look how open that is. You've got to be level all the way around. It's got to be equal all the way around. You can see stress fracture or avulsion fracture here, and you can see injuries posteriorly as well. Okay? So we're going to fly through this. But what about this case? What if the patient is 10 and they also have fifth metatarsal pain? So at the age of 10, their physes are still open. Remember, we talked about this. So you want to really make sure you're carefully looking at all the physes. And they also have fifth metatarsal pain. You want to make sure there's nothing going on there. Okay? What about a patient that's had recurrent sprains, has never gotten back to 100% pain-free? How do you treat that? How do you look at it? Someone who has recurrent sprains, and they keep coming with recurrent sprains, get a foot x-ray. Because someone has a tarsal coalition like this, and you can only see it on a foot x-ray. You're not going to see it on ankle x-ray. They are more at risk for having recurrent ankle sprains because they have immobility here in the midfoot, so their ankle is going to go on them. And you can get a CT scan to more clearly delineate that, okay? And again, here's some examples of other injuries that you can see on x-ray or CT scan. Now, this is an OCD of the ankle, the talus. Just like how we saw it of the knee, of the talus, you need to look. If they say they've gotten recurrent sprains, they've never gotten back to 100% pain-free, keep in mind a tarsal coalition, keep in mind the possibility that they could have an OCD. So don't be shy to get another x-ray. All right, hip pain. 16-year-old female martial arts athlete, right groin pain, decreased range of motion over 3 months. Worse with kicking and recent standardized testing at school. Sitting, okay? Complains of blocking catching, gave out, pain's not improved, just about rest. So she started running a month ago for exercise because that didn't hurt. Jogging didn't hurt, yet prolonged sitting and kicking hurt. Pain with flexion, adduction, internal rotation of the hip, or fader on physical exam, decreased hip internal rotation and flexion. Okay, imaging that we do. Okay, if you get an AP and frog of the pelvis, there's a lot of things that you can see. All right? So first of all, I'm going to jump over here. You've got increased sclerosis right here, okay? Femoral neck stress fracture. That can occur, okay? Down here as well, you can see that there's some early callus formation a fractured superior pubic ramus, a stress fracture there, okay? If we look right here on that first one, I'm going to kind of show you, you can see you want to look at the coverage of the head here. And in this part right here, that arrow is pointing to a crossover sign, which we can talk about later. I won't get into too much. But if you think about how the hips are, you can take a look at how the hip alignment is, how the coverage is, but look how little coverage there is of the acetabulum or the femoral head. So what oftentimes happens is several things can cause this person's pain. You can have what's called FAI. Now, you may look at it and go, wow, this looks funny. I just want you to know, when you look at an x-ray, is that there's such things as bony development here and over bony development here. And you can see that when that hip comes up, it can pinch and cause pain. All right? And remember, there's a labrum or cartilage there. So this is what we call, I try to send you guys your notes back when you send people to me, but I always try to send a note back. So when I'm talking about femoral acetabular impingement, that's what I'm talking about, is a pinching because of overgrowth here in the hip joint. Okay? And you should refer if you see anything like that. If anything's happening in the hip, there's multiple causes. It can be traumatic or degenerative, but it can happen in all kinds of activities, people who squat a lot as well, pivoting, and you always want to look for an underlying structural cause like hip dysplasia, right, or FAI. Imaging is very sensitive to do an arthrogram. Here's a tear of the labrum. You can see it here as well, and here as well. Okay, so that's an example of some hip things. Shoulder injury, we're almost done. 14-year-old right-handed male landed on outstretched left arm when playing flag football at school. A lot of pain, he couldn't move his shoulder, and 2 to 3 minutes later it popped into place and he could move it. He has a big baseball showcase next weekend. He's a pitcher, and can he play? So what do we get? We get pain. Remember, he's right-handed though, right? Right-handed, it was his left shoulder. Pain over the right anterior lateral shoulder, but he's able to externally rotate and internally rotate at the side. Actually, this should be left, sorry, left. Sulcus, apprehension test, relocation, but he has pain and decreased strength of his right shoulder as well. And there's no ligamentous laxity elsewhere in the body. Okay, so the shoulder is the most commonly dislocated joint. Here's an anterior dislocation, okay? And anterior is the most common way. Less common is posterior, all right? For the posterior one, if someone comes in, and I say seizures or football linemen, I've also seen it in people who fall hard and the shoulder gets pushed backwards with a fall, okay? And the way to look at it, and it's missed a lot, so if you're in the ED or you're doing rotation, okay, light bulb sign, all right, you should always have, you know, this is an example of you're getting overlap through here too. All right, so these are some things that you need to be careful about when you see someone with a posterior dislocation, and look for it and see this is too much overlap, okay, when it's doing that. All right, now, here's another example, and this is called an axillary view. Think about the shoulder like this, okay? It's a golf ball sitting on a tee, all right? And now it's turned, and this is how the shoulder is. So when we talk about a whole bunch of things, there's a lot of components in there that help keep that golf ball on the tee, help keep the shoulder in place. So quickly, there's our terms. This is a labrum, the cartilage. A Bankart lesion is actually a fracture of the bone off of it, okay? There's a bony Bankart and there's a cartilaginous Bankart. So always get x-rays. Physical exam, here's a sulcus sign. You pull the shoulder down, humerus down, and you get this gap here, right? Here's the humeral head sitting here. Here's your acromion. There's a gap there. That's inferior instability. Apprehension is where you have them lying down. You do this test. They say, oh crap, my shoulder's going to come out. Relocation test is if you put your hand there and they say, oh, it feels a lot better. So as you're doing this test, this hand actually should be sitting right here so that you don't accidentally pop them out of place. That would be not tragic. It's happened to me once. They don't like it. Okay? Always look for instability, signs of multidirectional instability. Look and see if they can do this with their joints, because it's really different in terms of how we treat atraumatic instability from traumatic instability. Okay? Surgeons do not want to operate on people who are loose. because that collagen will just loosen up again. So they like them to do physical therapy, and a lot of physical therapy. Imaging, here's your imaging that you can do, arthrogram, but axillary x-ray is really important because in an axillary x-ray, that's taken like this, okay, shot through, is look at the good position here of your glenoid, your humeral head, but in this position, you can see exactly what position that humerus is in. Okay, initial treatment, sling for comfort, and physical therapy. Okay, if it's recurrent instability, surgery. There's some thinking now that with one dislocation, maybe you should operate, but we're having this debate in the sports medicine world. But again, the initial treatment is this and this. All right, what about his right shoulder? Remember his right shoulder hurt? Look what happened when you image his right shoulder. Okay, this is the uninjured shoulder, and this is the dislocated shoulder. What's going on there? Okay, he's got little league shoulder on the right arm. Here's a widened physis, a growth plate, edema in it, and this is what happens. Excessive pitching, rotator cuff weakness, impingement. I see this all the time. I want you guys to know a differential of little league shoulder is rotator cuff inflammation. Children do not tear their rotator cuff, okay? Instability, impingement, or a tumor. So always get an x-ray, okay? This is what we do. We get x-rays to show separation. Sometimes there's no separation. Sometimes you're not sure. You can get the other shoulder. It's okay, all right? I believe this is why we have two. I'm kidding. But the thing is, sometimes you don't see a separation, but it hurts right here. And you can poke on it, and it hurts. So please, that's a Salter-Harris grade 1, right? Type 1. So stop all throwing, MRI only if failing conservative treatment in 3 months. That's typically what I do. But they've got to stop all throwing for 6 weeks, and you've got to tell them that. And basketball playing and doing anything overhead. I need you guys to know that there's, for anyone that has high school kids that come in and they do pitch, is that there are pitch count rules now. And you can find them online. And this is the California Interscholastic Federation. Well, it doesn't matter, though, if they're also playing travel ball for a club team. Okay, last case, elbow injury. 12-year-old right-handed male comes with a pop during his baseball game, right medial elbow pain. It's been off and on, actually, for the last month. He's been throwing multiple pitches, including curveballs, and he pitches almost every day at practice or with his pitching coach, because they all have to have pitching coaches or else they're not going to make it to college. And he's also the quarterback on his school's flag football team. So he's tender palpation of the medial epicondyle. He's got no tenderness over the capitellum, no ligamentous laxity. X-rays show here, affected side. You see how there's a gap there? Okay? That's his medial epicondyle. This is a medial apophysis. You know what flexors attach here, right? So he's pulling it. So that medial epicondyle, remember, ossifies between 5 and 7. Complete ossification is 14 to 17. So there's a lot of time here that kids are playing baseball or softball where they're putting a lot of stress on this ossification center, okay? Remember, the apophysis is weaker, and traction causes the widening. So the key, history and physical, insidious onset of pain. But what happens is they stop pitching, but they keep throwing. They move them to another position because they've lost their velocity or whatever. Decreased performance, loss of motion, tenderness, okay? All right, you can also get OCD, osteochondritis dissecans, but typically that's here laterally, okay? And ulnar collateral ligament injury, they'll be lax. However, I just treated someone that had this pain, about 8 weeks later, 10 weeks later, he's still hurt. Not so much diffusely, but focally. I never felt like he was lax, but I just got an MRI arthrogram. He's got a partial tear of the ulnar collateral ligament. He's 11. He's 11 years old. This is that whole Tommy John surgery. Okay, image both elbows if needed. And again, if x-ray is negative, consider an MRI. So remember these pearls, avoid any pitfalls. In summary, take a good history and be familiar with basic anatomy. Okay, or have an anatomy book. I do it all the time. I will bring the book in with me, And I look at them, and then I'll open it up, and as I show them what they hurt, I point it out on the anatomy book. It doesn't take more time, I believe. Well, okay, it does a little bit. But I think that's important for patient health, for getting them better. The location of the pain will lead you to the injury, but don't palpate for pain right away. In the skeleton immature, bones are weaker. Always make sure the patient can do a straight leg raise if they come in with a knee injury. Don't forget the tunnel notch and the merchant x-ray views of the knee. That they're available for you, you just have to ask for them. Fix the ACL to avoid instability, meniscal tears, and later OA. So what I would say to you is that if you suspect a ligament injury, you're going to refer them. But if they come back to you because you're a trusted pediatrician or family physician, you're the person that they trust, and they come back and they say, what do you think? Should I get my ACL fixed? That's what the surgeon thinks. Know that we like to do this because of everything that's going to happen later on in life for them. And there are ways to fix it so you don't affect the growth plate and they don't end up having a shorter leg. Physical therapy and strengthening the core, not just the quads, is the key for patellofemoral dysfunction. You've got to strengthen the hip so the knee doesn't go in. Maybe I'll do another lecture about physical therapy stuff that you can do with your patients who can't afford to go to physical therapy, who don't have the transportation. And ankle x-rays will mix foot pathology. So don't forget to examine the foot, and if need to, order foot x-rays, because an ankle x-ray will often miss a fifth metatarsal fracture. So don't forget to examine the foot with ankle pain. And lastly, comparison views can be helpful. Don't hesitate if you have a concern just to get the other side. Okay, thanks very much. I think we have a little bit of time, a few minutes for a couple questions, and then I can stay for a little bit before I have to head out to Walnut Creek. So remember, you can refer patients to me who have injuries and illnesses related to sports and exercise. Okay? And oftentimes I'll give them cream for keratosis pilaris and some other stuff that I see. Any questions? These are my kids when they were younger. They're now both in college. And they played a lot of different sports. Remember, diversification. Do not have them people specialize. I sigh because it's frustrating. I mean, I do a lot of sports, of course. You guys, oftentimes in your clinics, have kids that you just want to get going and moving. And I understand that too. I totally understand that too. So it's really, we need to get to a good place in our society where we've got two extremes right now, and we need to get them all here. So 30 minutes a day. 30 minutes a day is a mantra, okay? 30 minutes a day of exercise. Walking, when they have dogs, walking the dog. If they can't go out of their house because it's too dangerous, then exercise in the home. How can they exercise in the home? Dancing to music, video games. There's a lot of video games that they can get. Dance Dance Revolution often was really big. It's not so big anymore, but that was a great way to exercise in the house. And I would say probably most people have video games and TVs. So think about that, ways to exercise in the house. You can do body weight squats in the house. You can do a lot of fun things, paired things. So maybe another lecture I can do things about that too as well. Okay, thank you.